Good evening, everybody. Greetings from Shija Academy of Health Sciences, Imphal. And the topic for today's discussion is local anesthetic systemic toxicity. In 2008, BBC News reported on the death of Mayra Cabrera, a 30-year-old theatre nurse who died in 2004 within 2 hours of giving birth to her son by forceps delivery. IV fluids and syntocinon were commenced postpartum. Shortly after, she suffered a seizure and had cardiac arrest due to ventricular fibrillation, from which she could not be resuscitated. Investigations revealed that 150 ml of a 500 ml bag of 0.1% bupivacaine in saline had been administered intravenously in error. So this was a case in which epidural infusion was given intravenously. A brief overview of today's topic. After introducing the topic, we discussed the risk factors for LAST, the clinical presentation of toxicity, the mechanism of LAST, finally, the prevention and its treatment. So local anesthetic toxicity may be local or systemic. LAST is a systemic toxicity that comprises of neurological and cardiovascular features. Local anesthetic reaches the circulation via systemic absorption or accidental intravascular injection. Accidental IV is more common than arterial injection. Systemic absorption normally has a delayed onset. Despite widespread use of local anesthetic, awareness of LAST and knowledge of its management are lacking. LAST is always a potential complication and may occur with all local anesthetics in any route. So vigilance is important sometime after administration of local anesthetic, especially in an environment where the patient is less well monitored. The risk factors may be related to the local anesthetic, the block, or the patient. The type and dose of local anesthetic injection influence toxicity risk. Ropivacaine and levobupivacaine, which are S enantiomers, are slightly less cardiotoxic than bupivacaine. The very slow reversal of sodium channel blockade after cardiac action potential, which is a hallmark of bupivacaine, is considerably faster with ropivacaine. Both ropivacaine and levobupivacaine have intrinsic vasoconstrictor properties that may prolong the duration of action and slow the systemic absorption. Local anesthetics are assigned a cardiovascular collapse to CNS ratio. This is the ratio of the drug dose that is required to cause cardiovascular collapse to the drug dose that is required to produce seizures. Higher the ratio, greater is the margin of safety. Here in this table, we can see that bupivacaine has a CC-CNS ratio of 2 compared to lidocaine, which has a high CC-CNS ratio of 7.1. So this means that progression from CNS symptoms to cardiovascular collapse will occur faster with bupivacaine. Maximum weight-based doses of local anesthetics, they do not take into account the relevant patient factors or the site of injection. Hence, while selecting the final dose of a local anesthetic, all the particulars of a given block, the surgical site and duration, the site of the block, the size, and the comorbidities of the patient must all be considered, and the lowest effective dose should be used. Now, the site of block also affects the risk for LAST. We can see here that increasing uptake occurs as the vascularity of injection site increases. For example, intercostal blocks, they are more vascular and there's increased drug absorption with these kind of nerve blocks. Compared to single dose administration, continuous administration will lead to accumulation of local anesthetic in the blood and tissue, leading to increased risk for LAST. How the block is conducted, like frequent aspiration, incremental injection, test dose, use of ultrasound, all these factors can reduce the risk for LAST. Now coming to patient-related factors, extremes of age are important patient-related factors. Neonates and infants have low levels of alpha-1 acid glycoprotein. So there's increased free fraction of the local anesthetic. The elimination T half of local anesthetics is increased in children, so there's risk of accumulation with continuous infusions. They are also at increased risk of LAS because of their small size. So a small topical gel application, which might seem like a small dose, but it might be a big dose for the child. So the doses for repeat boluses or continuous infusions should be reduced by 15% from published standard doses for other ages in this age group. The elderly patients are also another group, patients at the extreme of age. They have reduced blood flow and decreased organ function, which lowers the clearance of local anesthetics. So the risk of toxicity with infusions or repeat boluses increases. They also have multiple comorbidities, which increases the risk for LAS. The nerves are more sensitive to local anesthetic block due to altered nerve morphology, reduction in axonal function, and reduced surrounding fatty tissue. So dose reduction offers safety in this subset of patients. Certain end organ dysfunctions will also increase the risk factor for LAS. Patients with cardiac disease like severe heart failure are susceptible to local anesthetic-induced myocardial depression and arrhythmias. There's lower liver and renal perfusion in patients with heart failure, which slows the metabolism and elimination. Even longer circulation time will delay the detection of an accidental intravascular injection. Patients with renal insufficiency have a hyperdynamic circulation, which leads to rapid rise in plasma levels after large volume nerve block. So it is recommended to reduce the initial dose by 10 to 20%. In hepatic disease, the local anesthetic clearance is reduced, while single dose blocks are unaffected, but doses for repeat boluses and infusions should be reduced. Note that alpha-1 acid glycoprotein is increased in renal failure patients, while it is still synthesized in patients with end-stage liver disease. Hence, this might offer some protection in this subgroup of patients against LAS. Pregnancy is also a risk factor for LAS. Hormonal changes increase the sensitivity of neural tissue to block and cardiotoxicity, while decreased levels of alpha-1 acid glycoprotein and albumin increase the free fraction of local anesthetics. Increased cardiac output causes rapid absorption after an injection, while epidural venous engorgement also causes absorption after an injection. Lower pseudocholinesterase activity reduces the chloroprocaine metabolism. The clinical presentation of LAS is highly variable, and it should be suspected whenever physiologic changes occur after administration of local anesthetic. The onset progresses through CNS excitation, followed by CNS inhibition, and cardiovascular excitation, and finally cardiac arrest. But only 60% of reported cases follow this classic presentation. Looking at lidocaine as an example here, we can see that initially initially subjective symptoms. They are CNS excitatory symptoms. So patient might complain of visual disturbance, tinnitus, lightheadedness, numbness of the tongue, circumoral paresthesia. As the levels rise, then CNS excitatory objective signs might appear. Patients might have convulsions, muscular twitches, and might also become unconscious. These are due to blockade of the inhibitory pathways. As the levels rise, the signs of CNS depression occur, like myocardial depression and respiratory arrest. Cardiovascular events occur after or along with CNS symptoms. Tachycardia and hypertension may be seen initially, while bradycardia and hypotension, which occurs at severe toxicity but might often be described as first changes. Dysrhythmias are seen in severe toxicity, which may be seen as conduction delays or ventricular dysrhythmias. Majority of the adverse events occur within 1 minute after injection of local anesthetic, but toxicity can have a delayed onset of more than 1 hour after injection, and it can manifest as isolated cardiovascular dysfunction or as combination of CNS and cardiovascular signs without the classical progression. This is a picture showing the normal mechanism of action of a local anesthetic. The local anesthetic crosses the neuronal membrane and it binds to its binding site in the sodium channel. So once it binds there, the sodium channel is blocked. So there's no entry of sodium ions into the cell. There's no depolarization, no generation of action potential, and thus local anesthesia is produced. Toxicity occurs when the local anesthetics affect the cardiac channels in the cardiac sodium channels or the thalamocortical neurons in the brain. The primary cardiophysiologic effect is decrease in the rate of depolarization in the fast conducting tissues of Purkinje fibers and ventricular muscle. And this is due to decrease in the availability of fast sodium channels in the cardiac membranes. Local anesthetics also block calcium influx and triggered release from the sarcoplasmic reticulum, leading to depression of myocardial contractility. They also interfere with cellular metabolic processes like oxidative phosphorylation, free fatty acid utilization, and cyclic AMP production. Respiratory and or metabolic acidosis both increase the risk of CNS toxicity from local anesthetic. When the PaCO2 rises, the cerebral blood flow increases, so more drug is delivered more rapidly to the brain. Diffusion of carbon dioxide into the neuronal cells will decrease the intracellular pH. This low pH facilitates conversion of the base form to the cationic form. The cationic form does not diffuse well across the nerve membrane, leading to ion trapping, and this increases toxicity of CNS toxicity of local anesthetic. Both hypercarbia and acidosis decrease the binding of local anesthetics by plasma proteins, hence increasing the free fraction of local anesthetic. Therefore, normocapnia should be targeted during episodes of LAS. PROM-assisted ventilation and circulatory support should be given to prevent or correct hypercapnia and acidosis, and also to prevent and correct hypoxemia, which exacerbates CNS toxicity. Prevention of toxicity is key to safer practice, and it starts with making sure that the work environment is optimized for performing regional anesthesia. Appropriate monitors should be attached, and judicious use, selection of the drug, the dose, and the concentration is all vital. Equipment for resuscitation should be immediately available in the vicinity of the theater. Effects of pre-treatment with benzodiazepine is often debated because benzodiazepines may reduce the seizure threshold, but benzodiazepines have other benefits like providing sedation during regional anesthesia, which is comfortable for the patient. Epinephrine 5 to 15 microgram is still widely used as a marker of intravascular injection. The endpoints with an acceptable sensitivity are increase in heart rate more than 10 beats per minute, increase in systolic blood pressure more than 15 millimeters of mercury, and 25% increase in T-wave amplitude in lead 2. But false negatives can be seen in elderly patients, patients on beta blockers, and patients with low cardiac output. Ultrasound, however, offers several advantages in regional anesthesia: direct visualization of the injectable spread of drug, detection of unintended intravascular injection, and use of smaller volumes of local anesthetic. And there's evidence that use of ultrasound can reduce the incidence of LAS. It is of does not always exclude intravascular placement. Incremental fractionated dosing should be the rule for all patients who are undergoing major conduction blockade. Continuous attention to the ECG, which include changes in the QRS and T-wave morphology, rate, rhythm, or ectopy, may be life-saving by terminating injection before a cardiac arrest occurs. Treatment includes early recognition and early discontinuation of administration of local anesthetic. We should ensure oxygenation and ventilation to prevent hypoxia, hypercarbia, and acidosis, and assess the cardiovascular status throughout. Start intralipid treatment early. The 3 pillars of last treatment include seizure management, advanced cardiac life support, and prompt administration of 20% intralipid. Resuscitation using intralipid is known as lipid resuscitation therapy. The mechanism of LRT is multimodal, but the lipid sink hypothesis provides a partial explanation. According to this theory, after giving an infusion of the intralipid, the expanded intravascular compartment provides like a sink for the local anesthetics to be for the local anesthetics to be removed from their receptors. These are some of the other proposed mechanisms of the intralipid therapy. The capture of local anesthetic, which is the lipid sink. The exogenous lipid provides a source of free fatty acid, and free fatty acid is available for beta oxidation. And as we know that the heart, so that this provides continues to provide a source of energy for the heart. The availability of free fatty acids also interferes with local anesthetic binding of sodium channels. Now, the intralipid also activates AKT cascade, leading to inhibition of GSK3 beta. AKT is a protein kinase that is vital for cell survival, for proliferation, and in apoptosis. And GSK, which is glycogen synthase kinase, its inhibition has a role in preventing myocardial ischemia reperfusion injury. Now, lipid therapy also promotes calcium entry, so providing a positive inotropic effect. And finally, accelerated shunting, which is also known as the shuttle effect, in which local anesthetics are shunted towards organs like liver. So how is this intralipid given? Initially, we give a bolus dose of 1.5 ml per kg over 1 minute, and then we follow it up with an infusion of 0.25 ml per kg per minute. After 5 minutes, we assess the patient. If cardiovascular stability has not been restored or adequate circulation deteriorates, we again repeat the boluses. So maximum of 2 repeat boluses of the same dose can be given. And we leave 5 minutes between boluses. So we give a maximum of 3 boluses, including the initial bolus. We continue the infusion at the same rate. If the cardiovascular stability has not been restored or the adequate circulation deteriorates. And we continue infusion until the patient is stable, adequate circulation has been restored, or the maximum dose of lipid emulsion has been given. At any time, we do not exceed a maximum cumulative dose of 12 ml per kg. This is a flow chart by Nysora. When once last is detected, we need to immediately call for help and start supporting ventilation, provide advanced cardiac life support. We need to alert the nearest cardiopulmonary bypass facility. If the patient is seizuring, we can give benzodiazepine like midazolam 0.05 to 0.1 milligram per kg IV. Propofol can also be given, but it can cause hemodynamic instability. Last resuscitation differs from standard ACLS guidelines in the following way. Epinephrine is used in smaller than normal dose, less than or equal to 1 microgram per kg, and lidocaine is not used in arrhythmias. Now, propofol. Now, the question is whether propofol can be used during LAST. So, propofol is prepared in 10% lipid emulsion, and it is never a suitable alternative to the 20% intralipid. Now, the clinical pearls to be taken back home are greater likelihood for LAST is there in petite patients, those patients with small muscle mass, extremes of age, and patients with pre-existing heart disease or carnitine deficiency. Roughly half the cases of LAST are atypical with no seizures or other CNS symptoms, only cardiovascular toxicity or delayed onset. The incidence of toxicity increases with injections near richly vascular areas. Best treatment is prevention. The prevention of LAST-related morbidity requires optimizing a complete system for regional anesthesia. Prevention of LAST also includes raising awareness and educating our non-anesthesiology colleagues about proper use of local anesthetic and the risk, including management of LAST. These are the references for the presentation. Thank you and all the best.
Very nicely covered, Dr. Kajal. Thank you so much. Just to add, what I found in my department is that we are conducting mock drills also for the LAST toxicity. So I have found it very useful just to train our residents. It's a good option and very well covered. And we should be also very particular after giving these interfacial blocks and abdominal blocks, because delayed absorption can occur of the local anesthetic and can lead to local anesthetic toxicity. And these pediatric patients, although the reports of mortality are very less, and there are no, as such in last 10 decades, there is no report of mortality from the LAST and pediatric age group. But definitely children, they do have LAST. So especially after penile block, after caudal block, and after the dental infiltration, there are reports in literature which are present. So one should be very particular. And I don't think there are any questions in the chat box. Do we have any questions? So very well covered.
Thank you, ma'am.
So Namita, if we don't have any questions, can we move to the second speaker? So our next speaker is Dr. Ruchi Ori from RML Hospital, New Delhi, and she'll be speaking on